Mobility. All right, and of course, you can check mobility if you've gotten them up and they're walking around, or if you've gotten them up to walk to the bathroom. You're checking their gait, you're checking their posture, their steadiness, all those things as you're doing something else. But let's talk about the different things that you would check. Of course, active and passive range of motion. Do y'all know what that is? Have you heard that before? Active range of motion means that they're doing what? They're able to do it themselves. So if I say pronate, supinate, they can actually do their own hand without me doing it themselves. Passive range of motion means that what? We're doing it for them. We're doing it for them. Now there are some range of motion positions, and I think there's this little picture there of him doing all kinds of different, and a lot of these different positions you can do in different areas. Did y'all talk about this in anatomy? Mm-hmm. The different range of, and probably in CNA too, hopefully. These are some of the different ones. Flexion and extension, can't you do that elsewhere besides the arm? The legs, right? Rotation, internally rotating, externally rotating. You can do it both arms, internal rotation, external rotation, and the feet and legs. Okay? All right. At this time, when you're doing these range of motion, that's when this last cranial nerve, those of you who've been real worried about that, comes into play. Okay. Number 11 is the spinal accessory nerve. Okay, and the way you test the spinal accessory nerve is the movement of the head and shoulders. So if you're having them move their head from side to side or up and down or shrug their shoulders, that is the movement of the spinal accessory. So when you're checking range of motion and you're checking their movement of their head, okay, having them move their head forward and back and side to side, that's spinal accessory. Okay, so the movement of the head and the shoulders. Okay. So now your cranial nerves are complete. Don't y'all feel better now? Okay, so spinal accessory. Sometimes you'll hear it just referred to as accessory nerve. And if you're doing your own Old Olympus Towering Tops of Fin in German, viewed A hop, then the A would be accessory. So if you're learning it that way, that's how you do it. Okay. Okay, we're talking about, we mentioned posture, shuffling. Patients who have Parkinson's disease, you're going to see that a lot, where when they're walking along, they're shuffling their feet. Okay, or if they've had a stroke, they may not be able to pick up their feet. Okay, some medications can cause you to do that, it can affect your gait. Limping, of course, that's what limping is. You've injured yourself. Foot dragging, again, that's a stroke. If they drag your foot. All right, you need to know the difference between lordosis, kyphosis, and scoliosis. All right? Lordosis is what happens when we're pregnant. Lordosis is sway back. So you see women doing this as they get further along, right? Their posture changes. There's a sway back posture. Why do we do that? Why does our body naturally do that? Center of gravity changes it so we don't fall forward all the time. So we're not falling in the floor on our face. So our center of gravity does change. Okay, that's a curvature in the lumbar spine. The lumbar spine. All right, so right here, this lower back, it actually changes when we're pregnant so that we don't fall forward. Okay, that's called sway back. Kyphosis is your older people. I have a touch of kyphosis myself because I have scoliosis. So you'll see the little hump right here, that hunchback, and you see some older people like this. Okay, so that's called hunchback. That is a curvature of the thoracic spine. Curvature of the thoracic spine. And then scoliosis is a lateral curve. It's an S curve. A lateral spinal curvature. You remember I guess well, when I was in school, I don't know if they still do this or not, but when I was in school, they took everybody to the gym, and you had to lean over, and then they went up and down the aisle and felt everybody's back. Somehow they missed mine at that point. I didn't realize I had a touch of scoliosis until 2 years ago. So if it's very mild, it's very hard to detect at that age, but that's when they start looking for it. Okay, lateral shaped curve. All right. Also under musculoskeletal, you're checking their strength, muscle strength. The way that you test muscle strength is have them flex their arms. You're standing on the other side, and you're trying to have them pull against your resistance. Okay? Or you pull against their resistance, and see if they can maintain that flexion. That's one way to test their upper arm strength. Testing their lower arm strength, if they're laying in the bed, put your hands up, have them put their foot against your hand and have them push against your hand, see if they can actually do that. And again, we're checking to make sure that both sides are equal. So if you're checking upper arm strength, you're having them pull or push against your hands at the same time. Or with their feet, again, they're pushing against your hands with their feet at the same time, because you want to see if one side is weaker than the other. And you would suspect that on patients who have had a stroke or have a neurological damage from something, a car wreck or whatever. The word atrophy, the term atrophy, means a loss of size and tone of a muscle. Okay? People who are bedridden, people who are wheelchair bound, people who are paraplegic, they're going to have a loss in the size of a muscle. Anybody ever seen that before? Where the muscles get very small? Because they're not used all the time. They're not constantly being rebuilt and strengthened. Okay. All right, body mechanics. Body mechanics. We talked a little bit about, remember how we talked about sensation when we were having them lay in the bed and we were moving their toe or their finger up and down and see if they could tell where it was. And we talked about people who have neuropathy or who've had a stroke can't tell if their toe is bent under or if their toe is bent up. They have a lot of damage, nerve damage. Proprioception is kind of the same principle. It's the sense of yourself where you are in space. So it's equilibrium. Are they able to sit on the bed and balance? Coordination, you're checking to see if they can do something rapidly. That's, they do this when they're testing to see if you're drunk. I've never had experience with that, but I'm just told that that's what they do. They take their finger, having them take their finger and rapidly touch their nose, see if they can do that with their eyes closed. You can also have them tap with their feet against your hands, see if they can keep the rhythm. That's one way to tell whether or not they're coordinated. That's a fine motor test, seeing if that part of their body is intact, and of course balance. There's a test called the Romberg test. Romberg. Romberg. And this is one thing that you're going to have to demonstrate and check off, the Romberg test. The Romberg test is you have them stand. You're standing either in front of them or behind them, and you want to make sure that your hands are to their side, because if they fall, you want to be there to catch them. Okay, you're having them stand with their eyes closed and have them hold their arms out to the side. Now, some people have them actually lift a foot to see if they can balance, but if they sway to the side, some people will, if they're really neurologically damaged, it doesn't matter if they lift a foot. If they close their eyes and put their arms out to the side, and they will start to sway anyway. They'll sway to the side. That's the Romberg test. So you want to make sure that they can balance with their eyes closed and their hands out like this. Okay? And again, your hands are here at their sides, because if they start to sway, you want to be there to catch them. You're not going to let them fall into the floor. Correct? Right? Yes. We're not going to let them fall. That's called the Romberg test. Okay? Reflexes. There are deep tendon reflexes and there are skin reflexes, cutaneous reflexes. Deep tendon reflexes, we use a reflex hammer in an office setting. We don't have reflex hammers in the hospital. They're few and far between. And if a unit does have one, they tend to get gone very quickly. So we have to figure out other ways to check reflexes. And your reflexes, you've got a couple of different ones. The biceps, I got a picture. Triceps, patellar, and the Achilles. The patellar is what you really associate with checking reflexes. That's right under the kneecap. There is an area, everybody will feel in their kneecap. Right under the kneecap, there's a little indentation. It's kind of a spongy little indentation. That's where your tendon lies. So when you're checking someone's reflex, you want to make sure that it's right you're not hitting the kneecap itself. All you're going to do there is injure them or hurt them. Okay? But it's right between the kneecap itself and your bones. You feel it. There's a little spongy area right there. That's where you're tapping, and you're gently tapping. And remember, I said we don't have a reflex hammer at the hospital. So what you're going to use is your stethoscope. And you take your stethoscope, you hold it lightly between your fingers, and you're going to tap them with the edge of your diaphragm. That's going to be your reflex hammer right there. Cool. Okay? That's what you use to test with. You can actually do it on your biceps and your triceps. Okay? That's what you're going to use, because it's a hard area, it's very narrow, and you can control it. Okay? So that's what you're going to use. For biceps, triceps, those are very difficult to elicit. Do not get all up in arms about that. For checkoffs, all you're going to be asked to do is demonstrate where you would use the patellar. We just felt for it, right? And the Achilles, you see how they're doing Achilles? He's holding the foot in his hand lightly, and then he's tapping. Everybody knows where your Achilles tendon is. Okay? If you gently tap the Achilles tendon, your foot should kind of jump up a little bit. Okay? Everybody get together with your partner. See if you can find the patellar and the Achilles. You may have to sit on the desk, because if your feet are touching the floor, it's not going to work. Okay? You need to dangle as much as possible.
It's hard to do. Yeah. Some are more I mean, I can feel my I can feel it. I've also had stuff that really don't matter. I'll eventually need one.
Thank you. that patellar tendon and they shoot that leg up at you, something's wrong, okay? That's called a hyperactive reflex, and it's associated typically with spinal cord disorders, okay? So you want their reflex to be somewhere between 2 and 3 plus. Again, that's one of those things that's going to take practice. Really getting that technique, hitting that patellar tendon, hitting that Achilles tendon. The Achilles, when you tap the back of their foot, the front of their foot should just jump. That's all you're going to see. You're not going to see this huge major response. Okay? Most of the time, they're probably faking it if you've got it. If you've got that. Okay? So 2 to 3 plus is where you want to see. And remember I said that with pulses, you never put NA, not applicable, right? We should have a pulse. Same thing with a reflex. If you don't have a reflex in that area, that's bad. Okay? That's very, very bad. There's some brain damage going on there. Okay? So definitely want to have some kind of response. So don't put NA for your reflexes. It may be hard to elicit. Okay? Hard to elicit. But it should not be 0. Okay, or you bury them. All right. The last part of our assessment is cognition, and that's the brain. Now, this is the mental status exam. Typically, you're going to see the cranial nerves listed in your textbook. It's going to be listed in this section because the cranial nerves are a neurologic exam. But I put them with all the other areas because it's easier, I think, to go ahead and test those while you're up there, right? If you're already up there with the eyes and the ears and everything, you might as well go ahead and do those. So, but if you do a lot better learning your cranial nerves all at one time, then you can put them at the end. It doesn't matter however you want to do it. I just think it's easier the other way. All right, let's talk about the other things, though, in the mental status exam. When you're checking someone's neurological status, one of the things that you're going to check is their memory. Okay, you're checking their immediate recall, their recent recall, and their remote recall. Immediate recall is the number game. You say, repeat after me, 3, 6, 9. And then they should be able to say 3, 6, 9. You just said it. They should be able to immediately say back what you said. 3, 6, 9. Okay? Recent recall, you could ask them, maybe it's 10 o'clock in the morning, and you can say, what did you have for breakfast? Okay? That was recent. That wasn't very long ago, just an hour or so ago, or 2 hours ago. What do you have to know, though? You have to know what they had for breakfast, don't you? They could tell you anything, but so you have to know what they had for breakfast in order to tell whether or not they're really intact. Okay? Or anything. I mean, anything. If you've been sitting in there with them and 30 minutes goes by and you've been watching TV with them and 30 minutes goes by and you say, what did they show on TV? What were they saying, a few minutes ago about such and such, to see if they remember. Okay, remote memory. You can say, what happened in 1492? Columbus sailed the ocean blue. Y'all remember that? Okay. What happened on September 11th, 2001? Most people now remember that. I mean, when I first started teaching this unit 11 years ago, that hadn't happened, and so we didn't have that as something we could use, but now we do, unfortunately. Right? So you can use that as a factor. I mean, it actually had happened. I guess it had happened, but I wasn't using it at that time. You can use that as something, but again, if you ask them something remote, you have to know what it was. Okay, don't just come up with don't say who was the third president of the United States. I don't know who the third president of the United States was. Who? Oh, well, that's scary. That's sad. That's very sad. That was an important one too. Which brings up another point. if you ask them something like that, what do you have to know about them? Their education level, don't you? Now, of course, I have a master's degree, which doesn't say anything about not knowing the third president of the United States. But you need to make sure that it's something that they should know, correct? You know, don't ask them to read something and repeat it back to you if you know that they can't read. And you are going to see that more often than you want to, okay? And people can fake it. People can fake trying to get you to think that they can read, and they can't. And you'll see a lot of clues. You'll hand them a piece of paper, and you'll say, "Can you read through that and tell me what it says?" And they'll say, "Oh, I'll read that later." And they put it to the side. That's a clue that they can't read it. More than likely, they can't read it. Okay, knowledge. Okay, ask them about, one thing you can do is ask them about why they're here. Why are they in the hospital? You know, if they're in there for abdominal surgery and they tell you they're visiting Aunt Sally, then you know that they're not knowledgeably intact. Okay? You need to make sure that they understand why they're there. Abstract thinking, that's always a fun one. Okay, you remember all those little rhymes that your mom and your grandma and your aunts and all that they used to tell you all the time? Like, what does "don't count your chickens before they hatch" mean? Y'all remember those? What are some others?
Early bird gets the worm.
Early bird gets the worm.
Burn the bridge
Burn the bridge before you cross it. Don't put all your eggs in one basket. Don't throw stones at glass houses. You know all those things? Those little abstract statements. Has everybody heard those before? Every once in a while I'll find somebody that says they've never heard of any of those. Those are abstract thinking. And so you ask them one of those phrases. What does "don't catch your chickens before they hatch" mean? Okay? So start thinking about it. Find one that you really understand. And see. And don't make it something that your family made up and you're the only family that knows it. That's not going to help, right? You got to make sure it's something that's fairly common. Those are abstract thinking. Let's talk about a problem called aphasia. And this kind of goes along with this condition, these problems when you're testing these mental status things. Okay. Aphasia. There are two types of aphasia. And these are abnormal, these are problems. Okay? Two types of aphasia. The first type is receptive or sensory. You'll see it said both ways. Receptive or sensory aphasia. Receptive aphasia means that you're talking to them and they really have no idea what you're saying to them. They don't understand. It's like you're speaking a foreign language to them. Have you ever, like when you go, or if you don't speak Spanish and you hear them talking and you don't understand what they're saying, that's what it sounds like to them. Even though you may be speaking perfect English to them, it sounds like a different language. It sounds garbled. Doesn't make sense to them. That's called receptive or sensory aphasia. The second type of aphasia is motor or expressive, and I think this one is the saddest type of aphasia. They understand what you're saying to them. It's perfectly understandable to them, but they can't respond back to you, and they get frustrated. They get so frustrated. Your stroke patients, this happens to them a lot. Or Parkinson's patients, this happens to them a lot, and you feel so bad because they know what you're saying to them, but if you ask them a question, they can't respond back appropriately, and you can see it on their face. It makes them angry and it makes them upset. So I think that's probably the saddest type of aphasia. So you got two types: receptive or sensory, and motor or expressive. Does everybody understand the two? Receptive or sensory, they don't understand what you're saying. It sounds like a foreign language. It sounds garbled. Motor or expressive, they can't express back to you a response, an appropriate response. Okay. Next thing you're going to check is association. Okay, their ability to associate something. All right, so you would say a dog is to a beagle as a cat is to a Siamese. What is the association? There's types, right? There's types. A type of dog, a type of cat. An oak is to a tree as a, and you can do it this way too. An oak is to a tree as a rose is to a flower. Bush. Never had anybody do that. Never. And just get it kind of, that's your own little routine. Judgment. How they process a thought. So you can ask them, what are you going to do when you leave the hospital? Okay, if they tell you that they're going to go enroll in a skydiving class and they just had abdominal surgery, well, their judgment is poor. Okay, you want to hear them say that they're going to go home and rest and they're not going to go back to work for a couple, that kind of thing. How's their judgment? Okay, there is a scale called the Glasgow coma scale, and you're going to need to know this for the test. Okay, there are 3, and the only thing you need to know is not the specifics. The only thing you need to know is the 3 parts to the Glasgow coma scale. But if I say, what are the 3 parts to the Glasgow coma scale, you're going to say eye opening, motor response, and verbal response. Okay, eye opening, motor response, and verbal response. Do you think you can do that?
Yeah.
I'm not going to ask you to add up numbers and stuff because you will have the scale in front of you when you're doing a Glasgow coma scale. But what it's telling you is how alert and active are your patient. So eye opening, it goes from spontaneous eye opening, that they open their eyes on their own when they need to they never open their eyes. Maybe they're comatose. Okay, motor response. They obey a command that you give them. They only respond if they're in pain. So if you've got a patient who has a broken arm, the only time that they actually will respond to you is if you move that broken arm and then they holler out in pain. But if you're shaking them and saying, or talking to them, they don't respond. That would be that. Normal flexion, they withdraw to a touch. They withdraw. Abnormal flexion would be your patients who have some kind of spinal injury. To none. Verbal response. Okay, they're oriented. And does everybody know what alert and oriented times 3 means? Have you ever heard that? When you describe someone as alert and oriented times 3, that means they're oriented to person, place, and time. Now, you may have somebody who is not alert and oriented times 3. Maybe they know who they are, and they can tell you what time of day it is. They may not can say, oh, it's 10:45. They may say it's morning, but at least they know what time of day it is. But they have no clue where they are. Okay, so that would be alert and oriented times 2. And then when you're doing your assessment, you would write alert and oriented times 2, not confused to place or not oriented to place. So you would describe the abnormality. Okay, so orientation, confused, inappropriate words, incomprehensible words. Those would be your aphasia patients. They would have incomprehensible words. Those patients who have motor or expressive aphasia, their words don't come out the way they should. Okay, so you rate your patient according to those 3 areas. The highest possible score is 15. Anybody below 15 has some kind of abnormality that needs to be addressed. And most of the time, those are safety issues. Some kind of safety issue. Okay, so again, when I'm asking you on a test about the Glasgow coma scale, I just want you to know that there are 3 parts: eye opening, motor, and verbal. Okay? Okay, so here's the levels of consciousness. This is just another little picture. You got somebody who's alert. This is AVPU. only verbal stimuli, only to painful stimuli, and unresponsive. That's kind of a similar thing to your Glasgow coma. Okay. And really, the last couple of slides are just some more little memory aids. Cranial nerves, we talked about that. 12 cranial nerves. Way to remember. Okay, any questions about this part of the assessment? Okay. Yes, sir.
I have a question.
Okay.
I'm looking at the mental status,
Uh-huh.
and I'm thinking about all the patients we get that you need an interpreter for.
Yeah.
That seems very hard